tight schedule, and it's really early in the morning. I really appreciate you're all here. My name is Cesar. I'm currently a clinical fellow at Hospital for Special Surgery. I'm also a member of the Weight-Bearing CT International Study Group, and I'm a consultant for Curvebin. So I really welcome you to wake up that early and join us for this early meeting. Just want to introduce the people that are going to be speaking here today. So the first person will be Dr. Bursens. He's an orthopedic resident at Ghent University, Belgium. He's coming for a research fellowship with Dr. Saltzman and Dr. Barg this next summer, and he's part of the board of the Weight-Bearing CT International Study Group, and he will be talking about why should people become a member of the Weight-Bearing CT group. And Dr. Barg was one of our speakers. Unfortunately, he couldn't make it. He's in a process to get his green card, and he's now has like a interview in New York City for the green card, so he couldn't make it. So Dr. Burson is going to give Dr. Barg's talk. So it's a literature review of what we have for weight-bearing CT in the literature. Then I have the honor to present Dr. O'Malley. That's one of my current mentors. He's associate professor at Weill Cornell University. He's one of the attendees at the Hospital for Special Surgery and a team physician for some of the important New York City sports teams, and he's going to present about weight-bearing CT of the foot and ankle in the treatment of professional athletes. And we're trying to get Dr. Easley here for a while, and we're really happy to have him here. Dr. Easley, you all know him, associate professor of the Duke University, past president of the AAOS, and it's an active member of the weight-bearing CT group. He's going to be presenting weight-bearing CT versus standard CT for the foot and ankle. The devil is in the details. And we have Dr. Richter. He's the head of the Department of Foot and Ankle Surgery in Hamburg and Nuremberg. He's the past president of the European Foot and Ankle Society. He's the current president of the International Federation of Foot and Ankle Societies, and also the president of the Weight-Bearing CT International Study Group. And he's going to talk about the scientific background, weight-bearing CT for angular measurements and correlations with pathography. So I want to welcome Dr. Bursens here for the first talk.
Thank you very much, Cesar, for the kind introduction, and also from my side, welcome to this interesting meeting. I'm going to talk about the membership and how to apply for it. So basically we have three main categories. We have our active membership, our standard membership, and our academic affiliates. In order to become an active member, you have to be involved in the research regarding the weight-bearing CT. So the requirement is to have one publication in the field of the weight-bearing CT and to send an email to our address depicted here, together with a short motivation and a CV. And if we receive this message, then you will be noted as an active member. These are our current active members involved in the study group. We have Professor Easley, Professor Ellis, Dr. Butts, Professor Godoy, Professor Den Hartog, and Professor Sean are currently involved. To become a standard membership, you have to be interested in the studies regarding the weight-bearing CT. They are mentioned here. The login credentials you can receive after applying for this position. They give you contents to the websites and the studies that are performed, and they also keep you updated concerning the forthcoming events. You have to send a short motivation together with the CV to our email address depicted on the screen. These are our current standard members. Our last category are the academic affiliates. These are university-connected people performing also studies in the field of the weight-bearing CTs, who are not particularly foot and ankles, but already contributed a lot to the insights into, for example, the biomechanics of the foot and ankle. And for them, it's also the same principle of sending a motivation and CV towards the address of our study group. And for the moment, these are our academic affiliates involved in our study group. We have Professor Line, who is very famous for his shown insights in the ankle biomechanics, as the same for Professor Siegler. So in conclusion, I think there's a nationwide member panel and expertise in our study group, and this of course results in numerous scientific inputs and advantages. We try to bundle these on our website and on the newsletter. If you become a member, you can stay involved and stay up to date regarding these aspects. And of course, like today, it allows a platform to discuss our findings, and you can pick out and choose the relevance for your clinical practice. So again, thank you for joining, and I hope you will apply for our forthcoming membership of the study group. Thank you very much. As Caesar mentioned, Professor Bark unfortunately couldn't be here, so I'm honored to give this presentation on behalf of Dr. Bark concerning the overview of the literature regarding the currently performed studies regarding the weight-bearing CT. This was recently published in this review here depicted. They performed a thorough review, as you can see here, and importantly to note is that they pointed out between 2013 and 2018 already 13 studies, and it's like it mentions here, not this simulated weight bearing as was performed before in the CT scan, but really the true weight bearing, as you can see here. This first study in 2013 was performed by Colin. It was a group of hallux valgus patients compared to a group of patients that hadn't had any deformities in the control group. And it was interesting to note that the controls, as you can see them here, they had no difference in weight bearing versus weight bearing, but once they had a deformity, once they have this hallux valgus present, you could clearly show that there was a significant increase in the deformity during the weight bearing. The second study was performed by Hirschman. It was a heterogeneous group, as you can see here. They included different pathologies, and the main pathology they could find differences for was the hindfoot alignment when comparing the weight bearing versus the non-weight bearing. Then there were the studies of Professor Richter. The first one was also comparing the weight bearing versus the non-weight bearing, but it was one of the first to show the angular parameters were accurately performed in the weight bearing CT. Another interesting study by Professor Richter was incorporating into the weight-bearing CT device a pedography. So by this you had the advantages of both the weight-bearing images and the pressure distribution around your foot in one examination. Then there was a study of Kim, also looking at the forefoot, and there they described the rotation of the first metatarsal, and based on this they even made a classification, as you can see here, where you could mention and notice the subluxation of the sesamoids. The study of Greenboom looked mainly with the Swiss group at the orientation of your subtalar joint, which was now clearly visible with the weight-bearing CT, and there were these types of configurations, and the configuration that was mostly found going from the front to the back of the foot was a varus and valgus configuration. And they compared this in a control group and also a varus and valgus osteoarthritic group. Then there were the studies of the group, the Finnish group of Lippervoy in 2016. These were based on a normal cohort, but they showed some interesting findings, mostly looking firstly at the rotation of the talus, and they used different positions of the patients using flexion or extension, and they see how the rotation of the ankle was changing. And the same they did for the distal tibial fibula joint. In the same joint, in the same cohort of patients, they did these positions, and they assessed whether this had influence on the distal tibiofibular joint, and of course these measurements in this normal population can be compared, for example, in forthcoming studies on pathology regarding syndesmosis. These measurements before were all performed manually, and Dr. Lins was actually one of the first ones that introduced automatic measurements to the weight-bearing CT. You had to point out, together with this TALAS software, different landmarks in the foot, and based on these it was calculated a foot and ankle offset, in which actually the deviation of your heel towards your weight-bearing plane of your foot could assess how much varus or valgus you had in your hindfoot. Another accurate measurement study was performed by Caesar. It was published in JBJS, and you could see here in this pes plantar valgus foot already many differences between the non-weight-bearing and the weight-bearing. The joint study of Professor Richter and Dr. Lins is noticed here, in which the TALAS software even had a good correlation with the pedography incorporated inside the weight-bearing CT device, and this is of course making it very interesting to have this biomechanical aspect connected to your images. This is our work that we performed, mainly looking at the hindfoot, both in pathological and normal conditions, where we found when attaining different measures you could either have more a valgus alignment when you use the inclinated views that were used before in radiographs, or now that we have the more straight views, this clearly impacts our alignment, as you can see here. Then there was another interesting study, also quite recent, about Weber B ankle fractures. We know in these sometimes not very much displaced ankle fractures that there is always a discussion, should we operate them or not, and there they used the weight-bearing CT to stress these fractures, and based on if there would be some kind of medial clear space widening, then that would give more arguments to give a surgical correction. One of the last studies that will be discussed was from the group of Kim, where they looked at deformities in osteoarthritic population concerning a varus deformity, and they clearly found a higher internal rotation depending on your increasingly osteoarthritis. So in conclusion, I think our future directions will be mainly looking at, because you see all these different measurements, that we will try to, in a sort of group effort, try to bundle these measurements in order that the studies that will be performed will be more uniformly performed. But of course, you will notice once you have the device, you will see more and more applications. And I think that's the advantages of this symposium today, that we will discuss by every author that's seeing his applications and numerous advantages for this device. Thank you very much for your attention.
I'm gonna get Dr. O'Malley here for his talk. We're gonna open for questions at the end, just because of the tight schedule. We also, Dr. Easley has a meeting, so after his presentation he's gonna get to leave, and maybe we can open for questions to Dr. Easley before he leaves, and then we do all the other questions at the end. Thank you.
Good morning. Really early morning. Caesar asked to give me this talk on my experience with weight-bearing CT and professional athletes. It doesn't have to be professional athletes. It's I work in New York, and there's a lot of agents in New York. We take care of 5 professional teams, so I have a lot of experience with treating these guys, and it's been helping me a lot in the care of these players. So the way I use it for the players is mostly syndesmotic injury and Lisfranc, but I'll also use it for ankle fractures, stress fracture diagnosis, and I'll do a lot of stress dorsiflexion and plantar flexion views. So I'll start with syndesmosis. We know it's a very common injury. It's more common than we think, but we know there's no universally accepted diagnostic and radiological test. What we're trying to prove, it's not the blown out Weber C fracture, it's the type 2B, and is it stable or is it unstable? And we know that stability, there's no radiographic normal. There's a a review, 70 citations, and the conclusion was syndesmotic injury instability poses a diagnostic challenge with unreliable clinical tests and inconsistent radiologic measures. And I think probably weight-bearing CT will be the best to answer this. The diagnosis is clinical and radiographic, how to test for instability, and really trying to test for this unstable grade 2 before you get to the operating room. So the mechanism of injury is all the same. It's external rotation, usually if someone's landing on your foot. We have the 4 joints. I think this is going by itself. 4 joints, the fib joints. I mumble, and if we go this fast, I don't have time. We had the anterior ligaments go first, and we're trying to really determine the grade 2, the unstable syndesmotic injury. So there's a combination of radiographic tests, and the question is, why do we really care? Because these patients with dynamic instability who have a long time to recover from a high ankle sprain and may have chronic pain. So here's a guy on the right who's 6 months from his high ankle sprain, and that's his MRI. With chronic pain in the anterior lateral gutter, he cannot return to play. And the problem is, here's another guy who was a 24 NFL player, approximates no fractures, treated with a couple tight ropes. That's his sort of post-reduction in the middle. He came to see me. Here he is on the right, and here's his weight-bearing CT. This is not going to be good. Salvaging a syndesmosis is very difficult. And the reason salvaging a syndesmosis is difficult, we know that the syndesmosis, there's normal motion in the ankle requires the fibula to translate, rotate, and migrate. And that study, I've had that study as well. The fibula has to move. And anything you do to try and salvage that failed syndesmosis is to make it too tight. Physical exam, there's a ton of tests. Sorry. Ton of tests. External rotation, squeeze tests that's used, very common, but they're very unreliable. We know the radiographic tests, they overlap, but they're not very reproducible, and they're very great with rotation. Let's do it again. And they don't correlate with MRI findings. So even doing stress radiographs is hard to do because it's hard to stress a broken ankle. So the best place to stress, you're trying to stress in anterior posterior, not varus valgus. So what we've been using for the weight-bearing CT is we've been trying to stress them in. We've been trying to stress them in the weight-bearing CT. So I'll take them and I'll have them go and I'll have them try to recreate their injury while they're weight-bearing. Now some can do it, but most of these people we're talking about when there's a diagnostic dilemma can bear weight. It's not the guys with the blown-out ankle. So we'll have them do a stress internal rotation view and then have them do that. And then I'll just have them do a standing both ankles. So you have to have the ped cats. I believe it's only one that does both. So you have to have a ped cat to do both ankles.
Yeah.
We know that the stress is better if you push the fibula posteriorly, and that's really hard to do with an X-ray. Arthroscopy is great. That's probably the best test, but you're trying to get there beforehand, and I'm not sure what. I think that's been that became in German. Is that German?
It's German, but if you prefer Chinese, I can switch to Chinese. Do you want to start with it?
Yes. So when you scope someone for an unstable, this is the guy. I'll show you. This is the same case.
This one is moving. Is it good?
Yeah. You'll see the fibula go. This is just pushing posterior on the fibula after the acute syndesmotic injury. Okay, so here's where this comes into play. We know there's a lot of data on syndesmosis. There's coming a lot of data on CT weight bearing, and you're trying to determine whether you take an angular measurement or an area measurement. And so on the top side, you'll take some tangential measurements for the fibula to the tibia. On the bottom, you just take an area measurement. it seems, when we look at these with a lot of bilateral weight-bearing CTs and just regular CTs, there's so much variability between between patients. So the only thing you can do is you can compare the other side. You can't compare your CT scans to any normals because there's so much variation. And even if you look at this in foot and ankle, they published this, and their conclusion was the internal control of the contralateral ankle is a better reference than population-based normals, which makes sense. So if you have a professional athlete with a syndesmosis injury, you can really make a lot of difference in terms of making that diagnosis of 2A versus 2B. And these guys did this, and this presented last year at AAOS, in terms of using dynamic weight-bearing syndesmotic injuries. And they found that the ankles, that the area was what they found. The angles weren't that good, but the area and the syndesmosis, if that was increased, that was a sign for instability. It was correlated with arthroscopy. So here's this guy. Here's his MRI. He's got an anterior injury. You saw his scope. Here's his CT on the right. The area is bigger. Here's his med cap with a little bit widening. And we got 2 tight ropes in his back. And I probably have 8 or 9 guys with the same injury. On CT scan, they shift a little bit. It's a little bit shifted, and it's been correlating so far 100% with arthroscopy. And it's really made that big difference for me, because before I was, do I take this guy to the operating room and have to make a decision on the operation? Right there, do I do something and risk taking a professional athlete to the operating room and not operate on him, or can I make a decision before? And so far, if the weight-bearing CT, and if I can get him a little bit of stress view, it's correlating. It's been the same for the Lisfranc. We're not talking about the big displaced Lisfranc injuries. We're talking about these very subtle ones. We take standing x-rays of both feet. We try and do stress views. We take our plane x-rays. All this stuff is done before. We know the MRI is helpful. Look at the ligaments. The CT scan is good for gold standard. Look at the bones. The radiology people favor MRI over CT. This is American College of Radiology. Here's a 27-year-old linebacker, steps on someone's foot. Here's what his foot looks like on the right. Here's his plane x-rays that come in from this way. Here's the CT scans, stay on both sides, put them in there, it takes 2 seconds, see the flex sign. He's moved over a little bit. He was grossly unstable. So this, he got his fixation, and his heart wear out, and this helps a lot as well. I also use it a lot for fractures, for fracture healing. This is my before the pedography was discovered. This was me looking at the bottom of the ped cap and looking at these feet. We discovered that these NBA feet, the first thing I discovered was looking at the bottom of these feet, they have a big problem that's under the 5th metatarsal. A lot of these feet look exactly the same. Here's a guy that comes in with a 5th metatarsal fracture on the left side. We scan both feet. Everyone gets scanned on both feet. We're finding a lot of fractures on the opposite side. You can see on the right side of the bottom, he's beginning to get a 5th metatarsal fracture. It clearly has one on one side. I use it for ankle impingement all the time. I see a lot of NBA players at the end of the season, they'll have ankle spurs, and we try and do some ankle impingement. And we'll also use posterior ankle impingement in the dance population, really to do a standing posterior. And they'll come in their point shoes, and we get a posterior ankle view. This is another one as we did. She had posterior ankle impingement and a stress fracture of the base of the 2nd metatarsal picked up in one CT scan. So for me, it's really changed my life in terms of evaluating these people. It's allowed me to do one step before taking them to the operating room in terms for the Lisfranc and for the syndesmosis, and for the impingement and the ankle, spurs around the ankle and the posterior anterior impingement. It's really made a difference in my practice. Thank you.
Thank you so much, Dr. O'Malley. Great talk. We're going to have Dr. Easley now.
I've got more questions than answers. But we have a consistent radiology conference with our radiology team every other week. And so I always felt that with a weight-bearing CT, I can get the detail as good as with a standard CT. And really my question is not going to revolve around everything I've seen so far, and I know it's early in the development, but everything I've seen so far is about diagnosis, alignment in feet and ankles that have no hardware. So the question is when you have implants, and so I felt that I could see that just as well. So our radiology, the guy that runs all the CT for us, said, it's not as good. And you should not be ordering the weight-bearing CT because I can't get the detail. At our institution, all the interpretation goes through the radiologist, even though I do the interpretation myself. But they get paid and I don't. I'm not complaining. I'm just saying. But they're encouraging us not to do a weight-bearing CT when there's metal in place because they can't see it as well. So fusions or arthrodeses that we hope to go to fusion, and periprosthetic cysts. They don't think they can see them as well. So my title was The Devil's in the Detail because I thought, what that means, most of you know it probably better than I, but it just means that it doesn't seem like a big deal, but if you look at it closely, there seems to be a big problem with the feasibility of actually doing it when you get right down to the nitty-gritty. But just like everything else in orthopedic surgery, those expressions all have a German origin, right? If anything, probably weight-bearing CT, if you go back far enough in the German literature, you'll find it's already been invented years ago, right? My mother was German, so I also have it too. But this expression, the devil in the detail, actually comes out of German. Der liebe Gott steckt im Detail. It's right there. And then they say it might even be a way the European Union interacts. But anyway, I get off the point. Let me just show you a few cases of what I'm talking about, okay? And I really feel, I just want some ammunition, one, to go back to my radiologist, and two, to keep doing the weight-bearing CT so I can learn more from it in any situation. And three, I want to just introduce the idea to you that as you move beyond doing alignment, and Marty's talk was great with the instability issues. I mean, I think that's really useful. I need to just learn the technique of how to do it, and we'll apply that too. I just know, how do you do that acutely, and get it approved? I guess you have patients come in, they say, here's $2,000, here's $20,000, here's $50,000.
I have my own transplant account for 40 years.
Right, and so
if they don't charge it, then
you just
we just charge it for the next one.
got it. That's nice.
That's
Yeah.
it. But we try to do it.
Yeah, we have it. We don't have that luxury, unfortunately. But we pretty good team working on it. Anyway, but to then maybe translate to actually doing studies and things that are important to me. I'm taking care of some athletes, and everybody's an athlete. I mean, I've learned that, right? No matter how old. But I'm talking about patients with total ankles and looking at cysts and trying to make something meaningful, because you can also do a lot with alignment with the total ankle with a weight-bearing CT, I think. But at the same time, you want to be able to see the cysts well enough. And I want to go back and tell my radiologist that's going to be fine. So here's a 58-year-old guy. He had a right subtalar non-union. And this is his standard CT, where you can see it pretty well. You can see the alignment reasonably well, but it's not weight-bearing. But you can see that it's a non-union. It's not rocket science. So I did revision surgery for him to get that to fuse. And there's follow-up x-ray. And then there was a non-weight-bearing CT. I was actually had the luxury of getting one extra CT because of a study protocol. But I can see bridging trabeculation at 3 months on a non-weight-bearing CT, and that's what I'm used to seeing. But I was also at 6 months able to get a weight-bearing CT, and I tried to capture some of the same views. I'm not slick like you guys and just run through the whole thing and show you the whole CT scan sequence. But this I can see very clearly. I mean, there's no question to me with this relatively minor amount of hardware in there. And if you compare the two, the non-weight bearing being on the opposite side from the weight bearing there, I really felt like there was no difference. If anything, it might even be a little better in some regards on the weight bearing CT. And then the same thing looking at the coronal plane, but I got about the same views, and I really didn't think it was different at all. Plus I had the advantage of having a much more accurate hindfoot alignment understanding. I know you know how to measure the angles, I don't, but I have a better idea with a weight-bearing CT what I'm really looking at, although this may be one of the better Saltzman views that I've ever gotten at our institution. What about more metal? So I have a firefighter, he has ankle pain, and he had a non-weight-bearing CT to define his partially avascular talar dome. And then I did an ankle arthrodesis for him, hoping that it would fuse. I used anterior plating and a supplemental screw. And follow-up radiographs show what I did, and I can get some information from that, but typically not very much. When you look then at the non-weight-bearing CT, you can see it's still in a cast at 3 months. Usually I have him out, but I can't remember why he was in a cast. I think I was just worried there was some delay in healing. And you can see there that it anteriorly looks like it's healing fairly well. Posteriorly, and I don't know how important it is that you get the whole joint to fuse, but you want to have some idea what the spot welding is. I think that's important. So I think weight-bearing CT or CT in general can really help us, but we don't want weight-bearing CT to be excluded. So maybe you can measure how much healing really ends up being necessary, and I know we've looked at that to some degree before. So at 6 months, you can see here, this is a weight-bearing CT, and maybe there's a little more scatter there, but I think I can see the surfaces just fine. So I don't think the metal interferes there at all. And again, I have a nice hindfoot alignment that I can do some assessment with as well if I really scrolled through that and looked at it, that I know that I'm in valgus at the hindfoot. So there's the weight-bearing versus the non-weight-bearing CT. Again, from the side, maybe there's just a bit more scatter there, but I really feel like the arthrodesis, the bridging trabeculation there, is pretty easy to see despite the scatter, and I think that's what the radiologist kept telling me, that that's going to be the limitation. A 55-year-old, a revision hindfoot arthrodesis. So in other words, taking it to another step, even more metal in there. And if you look here, you can clearly see the non-union across the talonavicular joint. And I don't even know if the subtalar joint's completely healed, but the point is that now I have to go back in and put more metal in. This weight-bearing CT is still going to be acceptable for me to work with. So now I've got this massive metal in there, and I think that's what the radiologists are concerned about. They say when you see that, all that scatter, they can't make an accurate assessment of the fusion mass or the bridging trabeculation. So again, 3 months, I've got a non-weight-bearing CT, and you can see that there's bridging trabeculation, or at least what appears to be in all the planes that I've reflected here, and I added the CC joint. That's easy to see despite there being a plate across the CC joint that's gone on to bridging trabeculation or fusion. And the weight-bearing CT, I felt I tried to get some representative cuts as well, but I felt that showed the same thing. Maybe it's a little less clear, possibly, and we'd have to really do a true study where you do 2 CTs. I don't know if many institutions would approve more radiation at the same time, but these are fairly close together, and I feel like I can see the fusion mass just fine, even though I've really filled that whole transverse tarsal joint with metal. So is there really a big difference? I didn't think there was a big difference in this case either, even though I really had this covered with a lot of metal. So I don't see it. So I want ammunition to go back to my institution and tell them that. I'll just finish up with the 4th case of a total ankle. 4 years status post total ankle. The lady has absolutely no pain. She's my patient. She's been happy with this ankle, continues to be happy with this ankle, but I see them back every year, and I just want to make sure I don't miss something. So at 6 years, she came back and has no pain and perfect function, and she's ready to walk out the door. And I said, well, wait, we got to talk about this. You've got a big cyst forming there. And she says, was that a big deal? I said, yeah, that's a big deal. We need to not make sure it doesn't have your total ankle fail. And so I'm going to have to talk her into surgery, even though she doesn't hurt and has the same function she's had ever since she's had the ankle in. There's the non-weight-bearing CT. She has, again, no pain, but just she's lucky that it still has some bone ingrowth, but that cyst is progressively getting larger. So I actually took her to surgery and put her in a prone position and curetted the cyst and filled it with cement. Now, I could use bone, but in this case I used cement. And that was it, right? So that's what it looks like with the cement, and she does well. She took her a while. She's a little disappointed at first because I did surgery and she had symptoms from that, but after a couple of months she got over that and was back to where she was before. But then I started looking under the talar component a little bit, and it's harder to see in a capping prosthesis like this, and this is where CT really is important. So a non-weight-bearing CT showed that she had a cyst forming in the talus. Now you can see, I didn't include all the cuts, but you can see the cement that's there up in the tibia. That seems to have filled pretty well. But she's developing a cyst now in her talus, and she's just rolling her eyes thinking, now it's another cyst problem, and does she need another surgery for having no pain? But I then came back. I said, we're going to get another one in 6 months, and at that time I opted to get, it's the same patient, but I opted to get a weight-bearing CT. So maybe there's a little progression, maybe the cyst has changed some, but if you look at it, it's really exactly the same thing that I was looking at with the non-weight-bearing CT. So you can see here in the comparison top to bottom that I feel like I get exactly the same information, and in some regards, if you really scrutinize it and look at the detail, I feel like that maybe it's even better in some regards. So I don't know, but I feel like I with confidence can go back and tell my radiologist that that's a non-issue. Maybe there are other situations that I don't know about. But for me, maybe it's not. Maybe there's no devil in here at all, and maybe you guys all know that. But I don't see any studies out there yet that talk about metal, where metal's in place, or maybe Marty's done his surgery and now you do another repeat study to show the difference. Maybe you've done that with the tightrope, I don't know. But if you use screws for something or a fifth metatarsal, can you see around it well enough and then you make a difference?
I use a retainer.
Yeah, and so that would be interesting to study that too.
I have 30
Yeah.
fifth metatarsals and probably 10 vapors with a lot of hardware after stress fractures.
And you're seeing it fine.
We're seeing it fine.
Yeah, so I think that's
sometimes they'll go somewhere. The player will go somewhere.
Right.
And they'll get another CT. So I usually do it. I stay back. Usually they stay around. They come back in 6 weeks, take the CT to see if it's healed. They sort of start returning to play. I think they're
Right.
trying to return to play. And at some point they'll get another one right before they return. So usually get a non-weight bearing CT at 3 months. It's no difference to me.
Yeah, so I think just that it has to be open, and you already have experience with it, so I'm just throwing it out there. One was the ammunition for my institution, but two, that as we move forward, I know a lot of protocols have to be worked out first on the basics, but then I think this will be really useful to be able to combine once you put metal in, particularly with total ankles. And you want to look at alignment, but you want to be able to capture those cysts and know if they're progressing or not. And unfortunately, Duke lost yesterday. You guys probably don't care. But I went to the University of Virginia, so it's okay. We're still looking good.
Mark,
Yes.
pretty much everyone in this room, I got a sort of study proposal, because when you show that weight-bearing CT of the percent fusion, I'm thinking that needs to be our primary outcome criteria in analysis in fusion studies, if you're comparing bone graft, because we looked at this, and the way we think of outcome in fusion studies and the way the FDA asks about it is binary. It's either union, non-union. Now we've had the luxury of having a whole bunch of non-weight-bearing CTs and looking at correlating that with outcome scores. And it's not binary, it's a regression. And so the less you heal, the more you hurt. And so your patient has some healing and he's a bit sore. And the question is, when does he reach a threshold of requiring repeat surgery? And it's actually, does that really matter? Because we need to try and get as much healing as we can. So what I'd like to do is I'd like to get a bunch of CTs of patients' fusion mass and get their outcome score at the same time and strengthen that study by looking at percent fusion. And Peter and I were just chatting about how do you create an algorithm that will actually allow you to to determine the percent bone healing across that fusion mass. So rather, because we did it, each fellow laboriously going through each slice and actually recording the degree of fusion mass, but we need an algorithm to do that. If we did that, I think that would become the new comparator if you are doing one bone graft against another, or one fusion technique against another, to actually, as the primary outcome measure, not using clinical outcomes, because I think it's going to be more relevant. So if anyone wants to collaborate in that study, we should get together.
That was amazing. You start talking and then your partner walks in. How does that happen? It's extraordinary.
Yeah.
It's like they hear your voice and just relax. It's probably that way in Vancouver all the time, isn't it?
So if anyone's interested in that, contact me. Percent fusion and outcomes.
It's good. I think it's a great idea. Anyway, it was more of a question than a lecture. So, but I would.
Comment.
Yes, sir.
How does your radiologist justify the radiation dose, which is 10 times higher than the standard CT?
Right.
And it's almost the same, so I think he should. It's the other way around. The radiologist should justify why he wants a CT, not the other way around, because the radiation dose is much lower. It's available very easy. So
absolutely. So I think that's the next step, of course, to mention it. You're right. I think it's an old dog trying to teach an old dog new tricks, and I think maybe he's had a few where he didn't pay enough attention and was just used to his typical protocols. I don't know. Maybe there's some way. Maybe there is some less reimbursement that I'm not aware of for the radiologist. Now that doesn't apply to Marty, who owns his own.
So hospitals also has one of my partners.
Right.
But it's also, I think, a lot of this is driven by orthopedic surgeons. And so when it's driven by orthopedic surgeons, the radiologists get all nervous and they don't want
Yeah, it took us 3 years to get it. I think you guys had it, not yours, but
Yeah.
your partners had the
Yeah.
same problem at HSS.
Right. Because
Finally.
if we bring the idea to them as something better, they don't like it.
Right. But thanks, okay.
Thanks so much, Dr. Easley. Do we have any other questions to Dr. Easley since he has to leave? So, any questions? Okay. So now we're going to have Dr. Richter presenting.
Good morning. I just learned that I live in a real paradise because in our hospital we don't have radiologists. So we can run our conventional X-ray and weight-bearing CT ourselves, which is extremely helpful. So no discussion with radiologists in our department. When we discuss about this technology, the main question is it really better than X-ray? Is it really better than CT? The last talk was CT versus weight-bearing CT. Most discussion is about X-ray versus weight-bearing CT, weight-bearing X-ray versus weight-bearing CT. And the proposal is always, why don't you compare X-ray with weight-bearing CT? And I just want to point out that this has been done several times. It started 5 years ago. And I don't think it's a good idea to repeat the same study type again and again, because this kind of study is also with a higher radiation dose, and therefore I want to show the results of one of our first studies again, just to point it out, because not everybody is reading the old publications. And if you read only the abstract in PubMed, what many people do before they cite something, sometimes it's not enough. So I just want to show the results briefly of 2 studies that we have done. And the most important study design is something like this. So comparison, weight-bearing CT versus standard. The gold standard still is weight-bearing X-ray and versus CT. And what we really want to see, of course, is fusion rates. It's good, but when we go preoperative, we want to assess the deformity as good as we can. And the idea, before we had the weight-bearing CT, that was our standard protocol. What we did with the X-rays, 4 images, normal feet, dorsoplantar and lateral, metatarsal skyline view of both sides, sometimes Salzmann or hindfoot view, sometimes ankle, with different rotations. And what we had was the weight-bearing, non-weight-bearing CT. And we observed cases like this with a different orientation of the foot and a different projection. It could change, and several studies have shown that already. So this is the same patient, but there's a different projection, the central beam and different orientation. Or here, this is a different position of the foot, rotation, and you know exactly that the hindfoot alignment angle really depends on the rotation of the foot. And see here, this is the difference between the same patient, 27 degrees versus 22 degrees. And you can say, it doesn't matter, it's just 5 degrees. But if you do a correction and you're aiming for 5 degrees of valgus later on, it's the difference that you have 5 degrees of valgus or 0 degrees of valgus or maybe 5 degrees of valgus. So 5 degrees could really matter. And with a 3D CT, to say it again, and we must say it again and again and again, with non-weight bearing, you cannot really assess the deformity. And we have heard it before with the hallux valgus. The same is true for Charcot feet or whatever. The top is without weight bearing, so the talar first metatarsal angle is 11 degrees. And you see, well, maybe there could be an ulcer here, but I'm not sure. I'm not sure how risky it is. And then with weight bearing, you see it's 22 degrees, and then you see, there will come an ulcer here. And this really, really matters. And you cannot see this in CT. So what we have done, we had only 30 patients included because of the much more radiation dose. So this went through a IRB approval, and we were looking for 100 patients. Say that no, do just 30 patients, because all patients, they got a standard weight-bearing X-ray, they got a weight-bearing CT and a CT. So it's massive radiation dose, and therefore we just got an approval for 30 patients. And when somebody applies again for this, you must also mention that the study has been done. So you apply for something with a massive radiation dose for a patient cohort to repeat a study that has almost already been done. So please keep in mind also the study subjects and I don't know if it's the same, but in Germany something like radiation dose is a very, very important. So everybody is smoking or drinking alcohol, but the radiation dose, oh. Okay, so we measured at different angles in a standardized way, and we have 3 different investigators, and we measured 3 times, and the intra and inter-observer reliability was very high, and we also measured the time spent, and for me, time spent is also time spent of image acquisition, not the time spent that we have reading the X-rays, but the radiology tech, and the time spent for this is also a cost factor in my opinion, and we compared that. And this is how we measured in the 3D environment, we didn't measure the time spent for this measurement because we are working for at least 5 years now on the automatic measurement, and we made a very, very big progress in this. So I think shortly we don't have to measure by hand anymore, which is really cumbersome in the 3D environment because you must rotate, and then you must find the 2 bones you want to measure, and then you must define the diameter on one side, the diameter on the other side, and again on the one side and the other side, and then you must draw lines in between, and it's really, in the first version of the software, it was really cumbersome. So here you can see the lateral TMT, dorsoplantar TMT and hindfoot angle, and you cannot measure all angles on one plane, so you need several planes. And this takes time, but this is the measurement, and when we have automatic measurement, the time doesn't matter anymore. But what matters is the time for image acquisition, because this doesn't really change. And in our hospital, so the foot and ankle department is responsible for 30% of all X-rays. So the radiology techs, they really know what they do. And for the radiographs, again, it's a metatarsal skyline view, both feet dorsoplantar and both feet lateral, and this took 902 seconds, the image acquisition, because the patient has to go step up on this and step up on this and go down again and turn around and do this and this and this. And they do it all day, so they're not really slow. And they were complaining a lot when I brought this PET cut in. They said, what is he doing? What's this again? And what do we want with this? And how does it look? And we don't like it. But then they really liked it because it took only 270 seconds on average, the image acquisition. Not the scan as such, it takes only 60 seconds. But the image acquisition, patient goes in, you push on the button, stand still, and so on. And in a CT, it took 415 seconds, the scan as such. And there's a big difference on that. And this is why it takes so long. We are looking for metatarsal skyline view, and we created a device like this, and it takes time just to do it. So we are quite happy that we don't have to do that anymore. But this is more important, the difference. And there's no surprise when you do an ANOVA analysis of 3 different tests, and they are not equal, that you get a high difference, a high level of significance. But this first test only says that there's a high difference between these 3. And then when this is significant, you can look in the post-hoc test between between 2 of those 3. For example, PET cut versus X-ray and CT. And you see that not everything is significant, but for example, the second intermetatarsal angle is highly significant, different between gold standard, I must say, weight-bearing radiographs and non-gold standard weight-bearing CT. It was not the case for the dorsoplantar TMT, and was not the case for the calcaneal pitch angle. So obviously this can be also measured 2-dimensionally, the same way as 3-dimensionally, but all the others, as you can see here, are highly significant. And again, it's no surprise that it's different with non-weight-bearing CT, because we don't have the weight-bearing, but it's very important that there's a difference between weight-bearing X-ray and weight-bearing CT when it comes to angles. And especially when it comes to the second intermetatarsal angle, I think everybody here in the room is doing hallux valgus surgery. And for hallux valgus surgery, I think this is the most important angle. And if you don't have the correct angle, and we have even guidelines what you have to do and what kind of angle. And if the guidelines rely on an angle which is not accurately measured, it's a little bit concerning. So the first thing, it's faster, okay. It's only a cost factor. Maybe we have enough time to play around a longer time. But the most important thing is that the measured angles differ. But when they differ, it doesn't say that which one is correct. It just differs. But when you look in technically, with the X-ray, you have this positioning problem of the foot, and you have the projection problem with the central beam. And when you respect this both, and it's different between the weight-bearing CT and the standard X-ray, and only one can be correct because it's different. It must be the 3D, because you don't have the projection problems and you don't have the position problems in the 3D imaging. So from a technical standpoint, only the weight-bearing CT could be correct. And at that time, and this was published quite a long time ago, it always says PET cut, but it's the technology, so it's weight-bearing CT. So the second study, we were looking, now we knew about the position, but what about biomechanics? And I do in all my patients, I do weight-bearing CT and the pedography, because I want the pedography as a tool for biomechanic analysis. So if you look at the bones in X-ray or weight-bearing CT or whatever, you see only the morphology, but it's not the same as biomechanics. So what I really like is pedography, and it's pedobarography, but because we don't measure pressures, we measure forces. It's pedography, it's the dynamic pedography what we do, and I was interested in including it at the same time with the bone position measurement. And of course, this is not so far. This is not dynamic. It's only static. I'm looking forward to doing it dynamically also. And what we learned from the earlier study, that the bone position we can really assess, and does it correlate with the pressure and with the forces. That was the second study we did, and for this we got approval for 50 patients because pedography has no harm. There's no radiation dose or whatever. So we just inserted a sensor in the PET cat, as you can see here. And then we measured again some angles and also distances, heights of the metatarsal heads and of the sesamoid, because we thought, oh, if we have the height of the sesamoid, it must correlate with the pressure or with the force underneath. It was absolutely clear. And when I did the study, I was writing the publication already, and the headline was high correlation between bone position and pressure. And this is the measurements we did, and it was everything clear. The measurements in the weight-bearing CT were semi-automatic. In the pedography, it's automatic. It's very good because it's an algorithm, and it was developed, and it's quite clear. So this is what we see, and you see here, which looks very, very useful. This is the lowest from the distance, and you have the highest force under here. So it's absolutely clear. And we looked at case by case, and this is a qualitative or semi-quantitative analysis. And then we did the statistics, and that was a real surprise because there's no correlation. In the 50 patients, we didn't find a correlation between the heights of the bones or the angles and the pressure and the force. And this was quite disturbing because then I had to change the heading, no correlation. But I really like these kinds of things. I really like negative findings, because if everything is like expected, it's really kind of boring. But if you find something out which is not like expected, it's really not so boring anymore. But I cannot answer why this is. Maybe the case number too low, maybe because it's not dynamic. I think that could be the same reason. What do we need dynamic pedography? Do we need other parameters? And that's the reason why we performed another study, as mentioned by Arne, with the Thalers algorithm and the pedography. And there we found a higher correlation between foot center and center of gravity. And I'm looking forward to repeat the study with more dynamic measurement and other parameters. And the conclusion of this is that, which is also good for us, if you have a pedography, you cannot just conclude on the bone position. So you need some kind of X-ray or weight-bearing CT. And if you have weight-bearing CT, on the other hand, you cannot conclude on biomechanics completely. So both investigations, pedography, biomechanic measurement, and bone position measurement, they are complementary. So you cannot just do one thing. So, but if this would be the case, we could say, oh, we don't need X-ray anymore, just do pedography. It's faster, with no radiation dose, just do pedography and we see everything. Or the other way around. I know that pedography is not very common here, but I think it's really a very good method to assess biomechanics and to have more information that you don't see in X-ray or weight-bearing CT or whatever you have. So what is the future for me? The automatic measurement. We are very close, but we are very close for the last 5 years. So hopefully we are now very, very close. And César is doing most effort in HSS so far with a new algorithm, and he showed me yesterday, and I see now light at the end of the tunnel, so I think it could work in the next maybe 6 months or 1 year. What I'm also looking at is planning software. We have seen total joint replacement. I think we should have a planning also in 3D, not only 2D, whatever kind of. And of course, we need the entire leg. We have now one device that can go up to the knee, but it's only the knee or the foot. I'm looking for something having the entire leg, 3D, or the entire body, why not? And dynamic imaging, that's my demand for the last years. I want to have imaging through the stance phase of the gait, or also for athletes. You do, in dances for example, you do the demi-pointe position, and while you do it, you see how the bones move, for example, or in the other athlete, you do the rotation, and you see what happens during the rotation with the bones, and not a finite element, which is only calculation, but in real life. That would need other sensors, of course. And of course, I think that the integration of the pedography or biomechanic measurement as an addition could be a good idea for all companies. That they can say, okay, you can, in addition, you can buy a sensor which is in the device, and you can measure also biomechanics. Thank you for your kind attendance.